Welcome, everybody. We're going to give all of our participants another minute or two to log in, but make yourselves at home. Do recommend keeping your video off. That helps the bandwidth go to the audio. And we're glad to have you all here with us tonight. We do like to hear where everybody is from, so if you want to type into the chat box where you're logging in from, we'd love to see. It's 5:01. We'll give everybody just another minute to log in. All right, well, it's 5:02 here in not so sunny San Diego at 8 o'clock on the East Coast. So we're going to go ahead and get started. Welcome, everybody. I'm Dr. Laura Crotty Alexander. I'm an associate professor of medicine here at UC San Diego and a staff physician at the VA San Diego. And we are hosting the ATS COVID-19 Critical Care Training Forum tonight. So this is a forum that we run every Tuesday evening from 8 to 9 p.m. Eastern Standard Time. And tonight we're going to be talking about virtual critical care and the Tele-ICU in resource-limited and cross-cultural settings. So after this brief introduction, we're going to go into updates and controversies in COVID care. So this is one of our favorite sessions to run weekly so that we can all stay up to date on what's latest and greatest, or in most cases, not so great, and the options for treatment of COVID. And then we're going to go into Dr. Jess Mandel's discussion of how to partner with hospitals to help them provide the best critical care possible to COVID-19 patients. Dr. Mandel is our division chief here at UCSD and has chaired the ATS International Conference for the last 2 years. And then we're going to go into our final segment with Dr. Venktesh Ramnath, who is an associate professor here at UCSD. And we have two internal medicine residents who will join him in discussing Tele-ICU, virtual ventilator management, and virtual medical education in the time of COVID. Last week, we again had a COVID case. We went over best practices for caring for COVID-19 patients in the ICU. We had our updates and controversies, and we also went in depth with Dr. Atul Malhotra on mechanisms underlying hypoxemia in COVID. But this was just one of our 15 sessions run to date. And on the right, you see lots of the different topics that we've covered. So all of these sessions were recorded. They're posted for free on the ATS website. So we invite you to dig back and watch some of them. They're easy to find. If you type in ATS COVID Forum, that'll take you right to our page. And we'll post this link in our chat box as well. We will be asking you for feedback on today's session. This helps us plan the future sessions. So this feedback form not only tells us what you think of us, but also gives you the opportunity to say what you would like to hear about next on the forums. And of course, this session wouldn't be possible without my co-chairs, Dr. Viren Kaul, Dr. Nirav Shah, and Dr. Sushma Kribs. And we also have a team of trainees that help us, namely Alex Cypro, Cameron McGuire, Ali Ashkar, Neal Jones, and Mark Rolfson. And our ATS staffers who make everything happen, Lauren Lynch, Liz Guzman, Eileen Larson, and Rebecca Fish. So I'm very excited to be here tonight. I hope you guys are too. Thank you for joining us. And we're going to go ahead and move into Dr. Erica Lynn's presentation of updates and controversies in critical care. And if anybody has any comments or questions, please post them in the chat box. We have experts on the line to answer in real time, and we'll try and discuss as many as we can as well. So Dr. Nguyen, you want to take it away?
Yes, thank you for the great introduction. And as Dr. Laura Crotty Alexander mentioned, I'm a third-year PCCM fellow at UCSD, and I'll be hopefully discussing some of the updates and controversies in COVID based on the recent publications in the past week. Sorry. So we've had about over 1,000 publications in the past week, and this lecture won't even touch the surface on many of these. I just want to discuss the fact that the world hit sort of a grim milestone this past weekend. So Johns Hopkins COVID-19 dashboard did report a total of 23 million total cases with over 800,000 deaths. On a more positive note, the daily coronavirus cases in the US has fallen in many areas, including New York, Alabama, and California, but has continued to rise in the Midwest. I think one of the more interesting publications to occur in the past week was recently from Lancet. And so investigators really did screen patients with SARS-CoV-2 for this 382 nucleotide deletion in this variant. And while the majority were infected with this wild type virus, there was a smaller percentage who either had a mix or had this 382 variant. And interestingly enough, patients with this variant tend to have a milder clinical course with a lower odds of developing respiratory failure. And this may explain some of the discrepancies that we see in our clinic and in our ICU. FDA also issued an EUA for the saliva direct diagnostic test. And
sorry, I've been told that we have it in the slide presenter view, but for some reason it's not doing that for you guys. So let me just try it one more time. Hold on.
Yeah, just make sure you share the PowerPoint application, not the desktop.
My computer is battling with me and winning. All right, I'm gonna just change this so that it is a little bit cleaner looking, even though it will not allow me to do that. There we go. All right, let's try this. Go ahead.
Okay, is that okay? Is everybody seeing the normal format? I'm gonna assume that's a yes.
That's a yes.
Perfect. So the FDA did issue EUAs for EL Saliva Direct as well as this recent antigen test. The Saliva Direct test is actually really interesting in that it can detect nucleic acid from SARS-CoV-2 in saliva collected in a sterile container. And additionally, it does not require a separate nucleic acid extraction kit. And that's really important because sometimes these extraction kits can be prone to shortages. As you can imagine, there are a lot of different names from it, including the most recent Voice of America called it a spit test. And what about convalescent plasma as a therapy? So FDA did hesitate, but officially issued an EUA for convalescent plasma as a COVID targeted therapy. Some of the preliminary results from this observational study can be found online. It did include about 35,000 patients. Half of them were in the ICU and a quarter were on mechanical ventilators. And you may be hearing some of these statistics that have been out by Donald Trump. The one to remember is that the 7-day mortality rate was around 8 to 9% in patients that received convalescent plasma within 3 days, compared to 11.9 or 12% in patients who received convalescent plasma greater than 4 days. Note that this trial was not a randomized and controlled trial, so patients did not randomly receive either plasma versus a standard treatment group or a placebo group as this point of a comparison. And again, this information was sort of publicized on a preprint website, so the conclusions are not yet peer-reviewed and should be sort of taken with a grain of salt before changing clinical course, even though some things have been happening in the background. I do want to bring up mitigating misinformation during this pandemic. Again, this graph is from the New York Times tracker, and I actually really love it because it emphasizes some of the therapies that have promising evidence, including dexamethasone and remdesivir, but it also emphasized the number of therapies that have mixed evidence or not promising evidence, a total of 17 listed. And so again, these pandemics can create this system of confusion and can create opportunities for some substandard therapies that are touted prematurely, or also falsified medications that can be more easily introduced into the marketplace. So I'm very happy that the FDA and the Federal Trade Commission has been issuing some joint warning letters to certain organizations as well as certain products about whether or not their claims are truly accurate. And this is another graph from New York Times that details when vaccines are in the development stage. And just like the therapies, there is sort of an urge to develop a vaccine. And the concern from the public is that some of these shortcuts can compromise quality and can sow sort of distrust in the medical community. They did an online survey in Italy that discussed the initial spread of SARS-CoV-2 in Italy, as well as during the reopening. And it did show that the public attitude towards science as well as vaccine effectiveness has overall decreased. So it's going to be really essential in the upcoming months to really foster a sense of community and trust, and really allow this open debate for some of these concerns to be addressed. There are currently about 8 vaccines that are in phase 3 clinical trials, including, very excitingly, a mRNA vaccine. So the main advantage of having the mRNA vaccine is that it sort of avoids the need to integrate into the host genome with respect to DNA vaccine. So it's something to look forward to. We do actually have 2 vaccines that are approved. Both are based on adenoviruses. There's one from Russia and there's one from China. And again, note that the one from Russia, although it has been approved for early use, there is concern that the vaccine has not yet entered a phase 3 clinical trial. When we talk about sort of these clinical trials, not only is it important to talk about the therapies that are trialed as well as the process, but also who's involved in the clinical trials. We all know that the studies have shown a disproportionately higher rate of COVID-19 infection as well as hospitalization and death in minority groups. And again, this is not just explained by socioeconomic factors. There is concern that there are other biological and genetic susceptibilities. So it's really important that our COVID-19 clinical trials prioritize inclusion of a population that really reflects the pandemic in order for generalizability. And bear with me, we only have a couple more slides left. One of the things I think we're all sort of wondering is what is going to happen when the influenza season arrives. And I wish I knew the answer as well. We know for sure that the percentage of visits for influenza illnesses have decreased, but it is higher than expected for this time of the year. And so one of our bigger questions is, are we going to have a twindemic with COVID-19 as well as the influenza, or is the fact of social distancing going to already prevent the transmission of other respiratory infections? And again, I think there's going to be a lot more to come in the next coming months. And then I think our last slide is really something that I like to discuss to sort of set the stage prior to hearing from some of our expert discussants, Dr. Jess Mandel and Dr. Venktesh Ramnath. And we just like to talk about the changing face of medicine. The COVID pandemic has really led to the rapid advancement of telemedicine. But I think one thing to be mindful is the timing and the setting of using it, because there are patients out there that have that just may not be telemedicine ready. Again, these are patients who are elderly, who are less educated, who have a low literacy level, or just have a lack of access to computers or smartphones. There are definitely ways that we can, as providers, do measures to help optimize the encounter. But again, let's just all be sort of mindful of this sort of digital inequality. Again, having said that, there's definitely a time and place. And so we've been very, very fortunate and and I think it's been very helpful for us to have a Tele-ICU, and Dr. Ramnath has been really instrumental in its deployment. And I think a lot of the patients in Tijuana will, as well as the providers, will be very ecstatic about having this.
Awesome. Thank you very much, Dr. Lin. Always nice to hear what's going on in the world around us. So with that, we're going to dive right back into our next talk with Dr. Jess Mandel, our Division Chief of Pulmonary Critical Care here at UCSD, who's going to take us through his experience with, how UCSD got involved with helping the Tijuana hospitals. And in the chat box, I do encourage people to put questions and comments. We can have a full conversation in there as we go.
Great. Well, thank you, Laura, and thank you, Erica, and it's a pleasure to be here to talk. So we've established partnerships with Tijuana General Hospital and Mexicali General Hospital, and people frequently ask me how that developed. So really, I'm just going to talk about that development and then ask my colleague, Tim Morris, who has really been critical for some of the in-person efforts, and Venktesh Ramnath, who has been critical for some of the telemedicine efforts, to really weigh in as well. So first, sort of turn your mind back to about March or so, when everyone, New York City is getting clobbered, Italy is getting clobbered, in San Diego, we're starting to see our numbers edge up, and we are, stockpiling ventilators, medications, making our contingency plans. And, there never seem to be enough hours in the day to do all of this work. And we're sort of hearing peripherally that Tijuana is really starting to see a spike in cases and that things are very challenging. This was an article that appeared in the San Diego Union Tribune, another one in Los Angeles Times, but this was sort of the extent of my knowledge of what was happening there. And we were having all sorts of meetings, town halls, get everyone on the same page in terms of our surge planning and how we were getting ready. And I think at one of these, I asked the question, does anyone have a good sense of what's going on in Tijuana, and if there's anything we can do to help them? And, the answer was, well, we hear it's, kind of bad, but that's all anyone knows, and nothing going on at present. And I would like to tell you that I immediately jumped in and took this on as a project, but that wasn't the way it happened. The way it really happened was that within an hour, I started getting these emails and texts from other people who'd been at the meeting, and they would say things, and they had said, they would say things like, I heard you're organizing aid to Tijuana, and, and for the first day or so, I would politely correct them that no, that's actually not true. I just asked a question, but I'm not, organizing anything. But, by the second day, this kind of kept happening, and more people were emailing me and offering to help out and this kind of thing. And it was clear that there was a lot of interest on the ground in doing this and helping our neighbors, and that, someone needed to sort of step up and make this happen. So I credit my neighbors. When I lived in Iowa City, Iowa, we're living in a small town, I sort of learned that your number comes up. Your turn to run your kids' Cub Scout troop is going to happen. Your turn to, run everything is going to happen. That's how things happen. And I recognize that this is one of those moments, and I should step up and try to organize something. But I didn't really know how to do that. I didn't have a lot of contacts in Tijuana. But we all get by with a little help from our friends. So I'd been working with Nick, who's we all call Dr. Nick for obvious reasons, unless you're Greek. That pronouncing his last name I find challenging, and I frequently massacre it. But I've been working with Dr. Nick in terms of county-wide storage preparedness operations. And through that had met Jim Schultz, who was the president of the San Diego County Medical Society. And they were both eager to help. And Nick referred me to Andre Smith, who's a great guy. He runs the emergency department at Scripps Chula Vista, which is, at Sharp Chula Vista, which is, literally about 5 minutes north of the border, and they were very impacted. But in his spare time, he also is very involved on a volunteer basis in terms of being president of the board of directors of the Red Cross Hospital in Tijuana, the Cruz Roja. He also is in charge of the ambulance service, the emergency medical services in Tijuana, and was really able to make introductions there as well. I also got in touch with Lucy Horton and Linda Hill, who are two faculty members at UCSD, and they had worked extensively in Tijuana with some of the migrant caravans. If you recall, these migrant caravans, a lot of people had moved north to try to seek asylum in the US, could not enter the US, and then were sort of stuck in Tijuana. They weren't Mexican citizens frequently, they didn't have access to medical insurance and healthcare, and they had been involved in organizing healthcare for these groups and had some knowledge of Tijuana as well. And really through them and through Andres in particular, we were invited by the Secretary of Health in Baja California and the director of Tijuana General Hospital to visit. And that was very important. We didn't want to just, invite ourselves and show up and, say, hey, you clearly you need our, expertise here, so let us tell you what to do. That's not appropriate and it's not helpful. And we really wanted to, to ask them what we could do to help. And I think it's important to know at this time, we had no official status. It wasn't as if UCSD had told me go there and, represent UCSD and do this. And, Andres hadn't been told anything similar by Sharp or anything else. And we had no equipment. This was a time when it was all about the equipment. Can you get more PPE? Can you get more ventilators? We had really nothing except ourselves. But we went down and visited, and with, sorry, let me just fix this here, with Dr. Reyes Escamilla, who is the director, down to Tijuana General, and Tim Morris, who is also on this call, was very important in the assessments and everything else. And what we learned from them was that the strategy taken in Tijuana was to designate several hospitals as being exclusively for COVID patients and to try to separate the COVID versus non-COVID patients by hospital. And Tijuana General, which is the large government-run sort of safety net hospital, was caring for most of these patients. I think we were very impressed by the doctors and nurses at Tijuana General. They were very motivated, very devoted, but they were very short-staffed. A lot of the nurses and doctors had come down with COVID-19 and were out for that reason. The Mexican government had also asked that no one over the age of 60 be involved in the care of these patients as well, because of the perception that the advanced age really put them at great risk as well. So there's huge influx of patients and many fewer people to take care of them. And what we decided was it really would be hard to be helpful until we really had a working relationship, a sense of everything that was going on, and that the best way to do that was really to show up, to really volunteer our time and to send a volunteer time every day, 7 days a week, to work collaboratively. And ideally, it always involved a physician. Ideally, it involved a nurse and an RT as well, a translator if we needed one. And we did that day in and day out. And this was a big ask for the physicians because we really wanted consistency of physicians. We didn't want a different person every day who would, sort of not have a sense of where we were coming from, where we were headed towards, who might have slightly different views every day. So we asked people to donate their time. And, Tim was there for, we said you either have to sign up for the 5 weekdays or both weekend days. Tim was there for 2 of the weeks, really helping out. San Diego County Medical Society helped get us additional volunteers. Turned out UCSD provided about 80 to 90% of the personnel, although very key folks from outside UCSD as well. And importantly, UCSD sort of donated to the effort Stacy Holberg to provide administrative support, who is just fantastic. And we could not have done this without Stacy keeping track of everything, organizing everyone, scheduling everything, etc. So from May 18th to June 14th, we were there every day, 7 days a week. It was about 8 critical care physicians. Again, we kept those numbers low. 2 infectious disease physicians were able to join us and help with infection control and other issues. We had 4 RTs, 29 critical care nurses, and 4 translators involved as well. And we really focused on, ICU care, really optimizing proning, optimizing ventilator settings, weaning, nursing interventions, such as getting the nurses familiar with proning, pressor ulcer prevention, oral care, things of that sort. And then we identified equipment deficiencies, especially monitors, because of the numbers of patients intubated was so high. Some patients initially were ventilated but not monitored continuously. And then they were down a lot of ventilator humidifiers as well. So based on the experience of those team members and those daily visits, we presented the hospital director with detailed suggestions for improvements in care in multiple areas. And they were extremely grateful and extremely enthusiastic about those recommendations and working together with them to do that. And I should say, you know, because of the numbers involved, the doctors that we worked with in Tijuana had enormous experience in dealing with critically ill COVID patients, and the learning was absolutely bi-directional, and the collaboration was terrific. You know, since we started really seeing a lot of improvements in the processes of care there, collecting data about patient outcomes, but feel good about that as well. We were also given about $35,000 to purchase equipment from Tijuana General. About $20,000 of that came from the San Diego Rotary. The other $15,000 just through a GoFundMe page. With that money, we purchased, you know, desperately needed bedside and monitoring equipment. So at this point, every intubated patient is monitored continuously, at least for heart rate and O2 sat. And we use the remainder of the funds to purchase humidification equipment for the ventilators to help with some of these long-term ventilated patients as well. And then after that in-person effort, we really moved our focus to these ongoing teleconferences with Tijuana multiple times per week, as well as intermittent in-person visits as well. And then based on what was happening in Tijuana, the folks at Mexicali General Hospital got involved with us as well. Mexicali is a city of about 1 million people. That's about 2 hours away, sort of south of the desert of Imperial County as well. And I think we were very impressed. They were, you know, having a huge surge in patients. Again, very hardworking, very bright people. And in many cases, again, because of attrition, folks who really had not had pulmonary critical care training. You know, in Mexicali, similar to Tijuana, there were field promotions. And we had visits there as well. Tim spent, I think, 4 days straight down there working with them, set up telemedicine support as well as visits by some of our nursing leaders. But again, this was a big effort. A lot of our faculty from not only pulmonary critical care, Kit Tainter is in anesthesia. We had 2 folks from surgery critical care helping out down there as well. And this is just some photos. This is Tim Morris down there working with some of our colleagues. And as opposed to at UCSD and most places in the US where folks were isolated by room, you know, here pretty much the entire hospital was a hot zone. And once you change into your PPE, you're in it for your entire shift. And that posing challenges in communications, charting, all sorts of other things as well. And again, this has been a terrific relationship, a lot of great feedback from both sites as well. So at this point, we've really transitioned to about 4 sessions per week of telemedicine activities with both Tijuana and Mexicali, intermittent in-person activities as well. This was just, I guess, about a week and a half ago. We had sort of 4 folks from Tijuana rounding with us at Hillcrest. And it's worth saying that the lead you know, physicians here, Pablo is trained as a rheumatologist, Carla and Clemente trained as gerontologists, and now they are incredibly experienced critical care docs as well. And then one of the residents as well who was visiting us. We're also organizing an ultrasound course at Tijuana General. That'll be in the next week or 2. We actually hosted a visit from Cruz Roja. They're considering starting an ECMO program there as well. And they met with our ECMO folks. So you're going to hear from Venktesh Ramnath in just a little bit as well to talk more about our telemedicine activities in more detail. So I will stop there and happy to answer questions and turn it over to the other folks in the group.
Great, that's awesome. And yeah, I didn't know if Dr. Morris wanted to chime in with anything he particularly found challenging from going down to meet that awesome team down there.
But yeah, I got a couple of comments. That number one, it was a real surprise to go down there. I was sort of like the advanced troops to go down to try to establish some sort of rapport with the clinicians that were working there. And I think that was really vital for us to show that we were not only interested in sort of imparting some knowledge, but working shoulder to shoulder with them. So as Dr. Mandel showed, that the entire hospital was essentially a red zone. So as soon as you showed up to work, you got into the whole PPE and you stayed in it through the whole day, which posed some challenges, you know, for trying to understand people as they're wearing these masks. You know, one thing I learned was time your coffee carefully, because, you know, once you put the stuff on, it's on until 4 o'clock or so when it's time to come home. What was fascinating to me about this group was that, as Dr. Mandel was describing, the group was really thrown into this responsibility. At the time, the Tijuana General Hospital had no critical care doctors. They're all either too old to be there by law to take care of people, or they got COVID themselves and they were gone, or some of the critical care doctors just decided they weren't going to be part of this effort. So they went out into the community and they recruited people that had no critical care training besides the few months that they did during their residency. So that was true for the doctors and the nurses, et cetera. It was all essentially made right from scratch. So imagine, you know, just picture your own, you know, colleagues, you know, picking them out of the outpatient group and say, okay, jump in on an ICU duty. And they've been doing it ever since March, these same people. The other thing that I thought that was prominent was, I really thought it was going to be, I was going to go down there, it was going to be a piece of cake, you know, tell them a couple of pointers and everything is going to be fine. But these were the sickest patients that, you know, you could possibly be. And you know, there were, at the first day that I showed up, there were 30 ARDS patients all in a row, all of them on 100%, all of them on high PEEPs, and none of them with saturations greater than 90%. So there was already a challenge. And imagine trying to do that on the budget that most hospitals probably spend on business cards, and that was Tijuana General Hospital. So it was certainly a challenge to go down there and meet with them. I think that the personal interaction and going shoulder to shoulder with them was really helpful for the next phase that Venktesh is going to talk about. And frankly, it's an ongoing challenge. We made a lot of progress. We had a lot of expertise to share with them about mechanical ventilation, but the problem still persists, and they have a very, very sick population, and they still need ongoing help.
Yeah, and I think, you know, all of us just can't say enough positive things about our colleagues. They are working incredibly hard under very challenging circumstances, you know, very, very devoted to their patients. I think it's, you know, we've learned from their experiences, and certainly we've been inspired by everything that they're doing.
Absolutely.
Yes. What was the biggest challenge from like the administrative side? I mean, it sounds like really amazing that you just sort of picked this up and figured it out. And yes, like all these people helped you, but man, it sounds very daunting.
I mean, honestly, one of the challenges is that University of California, like all institutions, has a million rules. And I think one of the things I'm very grateful to UCSD for was that they were really willing to support this without insisting that they own it. And I think the fact that we could partner with San Diego County Medical Society, with folks, you know, from outside UCSD as well, and keep this a sort of quasi independent initiative, it just allowed us to be more nimble and move more quickly than I think we would have been able to do had it been, you know, a completely UCSD owned and official activity where the requirements for all of the, you know, legal, travel, everything, I just think would have been more cumbersome. And so I give a lot of credit to our administration for really supporting us without having to completely envelop us and bring us under there.
You know, one of the big challenges actually too is that there's politics involved in everything on both sides of the border, and there are certainly politics within the hospital system in Mexico. And
you're straddling the border right there, right? Your right foot is in San Diego and your left is in Tijuana.
Yeah, I can't see which one is which. But one of the things that happened when we first went down there was that the press got word of it. And the story that would sell newspapers was something like, you know, Americans come to save these terrible, you know, terribly run hospitals and that sort of thing. And it was quite embarrassing to the people that we were down there trying to help. And they, at first, were quite resistant to having much of what we're doing publicized. In fact, I was going in, you know, trying to avoid, there was always cameras outside the place, and I was trying to go in through other exits and avoid them. But eventually, I think, you know, by just, you know, expressing publicly the high regard that we have for these doctors, especially when the press did sort of corner us and made us into doing a statement, really led to a lot. And so I think talking them up was really helpful for them, because the last thing we wanted to do was to come in for a short amount of time, do a little tiny bit of good, and then the permanent result was that their reputation suffers from it, and they're worse off when we leave.
Yeah, and they never invite you back either. So agreed. Well, that's really great. I do want to go ahead and transition to Dr. Ramnath's section. But again, anybody on the line who has questions or comments, please do post them in the chat box and we will address all of them. And so with that, it's my pleasure to introduce Venktesh, who is all-knowing in things Tele-ICU, and really excited to hear about his program.
Well, thanks, Laura, and thanks for everyone for hosting this. I want to start with just sort of 3 themes to think about, as we've heard about from Dr. Mandel and Dr. Morris. One is a needs assessment, to figure out what is the actual need that you're trying to address, and we'll talk about that. Second thing is the trust. You've heard a lot about the people involved in this. And that is a crucial element to any program, including telemedicine. And then finally, education. If you're looking at trying to have something sustainable, you want to be able to teach people and get them on the same mission with you. And notice I left technology out of that, because technology is a instrument, but it's not the solution. And I always say, when I go into discussions about incorporating telemedicine, that telemedicine is really an augmentation of what we do. It's an extension of what we do every day. It is not a replacement. So with that, let me start with is this working? There we go. So I'm going to talk about resource limited settings and cross-cultural settings as well. And so this applies really to anyone, anywhere. I saw there's some folks from Saudi Arabia to the Middle East, other parts of the Middle East, and across the US. This really applies, this kind of framework applies to anyone trying to help someone who is different from you and in a different regional, geographic, cultural context. How do we use Tele-ICU in that context? We're going to focus on that in our specific region, which is the southern part of California, and looking at the cross-border challenges, but really using it as a way to become more aware about what is achievable. There's no ideal, there's no perfect scenario. And so how can we get to something that is going to get us to closer to the goal we're all trying to achieve? And finally, how do we develop skill sets in this weird time of COVID-19 where we can't touch patients all the time and we can't get our trainees in the room? Can we still develop and hone some skills? I would argue that we can, and Doctors Crisp and Jones are going to hopefully help support that theory. So first of all, what's a resource limited setting? I would argue that any context is limited. It's a subjective term, right? So what we're going to move away from is what an ideal is, some kind of, halcyon sort of era when everything was perfect, and move to something that's the best possible scenario. And when we talk about limitations anywhere, we're talking about resources that are either slow or unreliable, they may be intermittent, and they may be unavailable at all. And so some of the things we commonly look at are skilled personnel. So whether they are physicians or nurses, respiratory therapists, nutritionists, the domain expertise is crucial. Technology, obviously we're talking about telemedicine, but things like internet and Wi-Fi are not givens. Electronic health records also are not givens, and we actually ran up against that here. Equipment, sometimes we depend on imaging. That's not always available. We already heard a little bit about what Dr. Morris and Dr. Mandel took made a lot of effort to provide new parts. Even ventilator parts that were missing were crucial to improving the care. Certain medications. In Tijuana, fentanyl and other commonly used opiates in the US, they're just not available. They have to be creative with their analgesia approaches, and even personal protective equipment may not be a given either. Language can be an issue, and we certainly bridge that with some translators, but also Spanish-speaking staff. And, you know, looking back at technology, you know, data privacy and security is important, and even literacy. You know, Dr. Lin mentioned earlier about, you know, the outpatient context where telemedicine may not be totally received in the same way that we want it to be received. But that's in the outpatient context with patients, but the same thing applies to any staff in the hospital is trying to use a Tele-ICU system. If they're not able to understand how the computers work, how to train others to use that, you can have actual problems with retaining that staff, which is crucial to keep this going. Why do these exist? Well, it's no surprise, but costs are a factor, education, location. So, you know, the distance is always an issue. Sometimes environmental issues are there. The regions that we're in were extremely hot, even compared to San Diego. And so some equipment and other issues come into play. And then language, as we talked about. So what did we see as far as trying to build this partnership between the academic and the community hospital? In our experience, we saw variations that we had to bridge. There it came in various forms. Specialists were not universal, so different disciplines were not available in some of these smaller community hospitals. This was compounded by the fact that disaster management assistance teams, all designed to help, sometimes added to the confusion. We had ED physicians who were trying to operate as intensivists, and they didn't have the same skill set or the same experience. We had, in the nursing situation, we had neonatal ICU nurses actually in an adult ICU setting. That's a fact. And so they were comfortable with some ICU issues, but in a completely different, you know, point of view. We had a lot of traveling nurses from all over the US, and some of them were fantastic, but they didn't know the system. They didn't know if I were asking about, well, how can I order this test? They were learning along with me. The advanced treatment modalities like ECMO, that was only available in the highest, you know, the tertiary centers of the world. And even there it's quite limited. Even equipment such as an MRI may have limitations. So in one of the hospitals, El Centro, they had an MRI, but it was not ventilator capable. So it was completely limited. And EEG was also, it still is sort of a work in progress. Certain types of technology, so electronic health records were not universal. The access to clinical research protocols and even experimental modalities varied. And even simple, so-called simple things like bed capacity and the cost of care, and even how personalized our experience is, those all vary between the academic centers where we were primarily located at UC San Diego and the community hospitals along the border. So let me just illustrate how we approach this with a certain case, which is, I'm sure, familiar to many of you. A 49-year-old diabetes and hypertension. He has dyspnea. He's hypoxemic. He's COVID positive. He has to be intubated, and then unfortunately develops shock or vasopressors and oliguric renal dysfunction. This happened very, very, very frequently in this hospital in El Centro, which is in Imperial County, which is right across the border from Mexicali, so about 130 miles from us in San Diego. They saw about 50 to 60 COVID patients in their ED per day, leading to about 10 to 20 admissions that honestly had led to transfers because of the lack of capacity all over California. They were looking anywhere and everywhere to send these folks to get care. The ICU bed, the capacity expanded from 8 to 28 beds in a matter of 2 months, which you can imagine not only the infrastructure involved, but the staffing stresses. And as I mentioned before, it was 130 miles from the nearest academic medical center. And finally, this was a model that was not really designed for intensivists so well. There was a low intensity staffing model, meaning that hospitalists were commonly the attendings of record. And so there required integration and really team building on a whole other level, and that was separate from the technology itself. What did we do? Well, we implemented a Tele-ICU service by mutual agreement, really driven by really listening to our partners, the community hospital partner, they wanted to start kind of in a limited capacity. So we started with 4 hours per day every morning, and we started with 10 days a month, but that rapidly expanded to every day of the week. We had the luxury of multiple different disciplines in critical care medicine certification from UCSD. We had a two-way audio-visual connection, kind of like we're talking right now on Zoom. We use Zoom for our telemedicine. And so we would connect between UC San Diego and El Centro. So I'm going to focus the conversation a little bit more here on El Centro, even though we did use the same modality and we continue to for Tijuana and Mexicali for our conference educational sessions. So what did our tele-intensivists do? Well, we supervised examinations, which I will say, you know, took some coaching, because our respiratory therapists and nurses are not designed, well, they're not trained and they're not terribly comfortable having someone watch over their back, you know, about how they're examining a patient. So that took some doing. We looked at ventilator waveforms and actually deep dived into that, and I'll show you some examples. We reviewed everything in terms of medications, labs, all kinds of data. We then created comprehensive care plans. We documented everything in the record. We put a huge amount of attention on collegial communication so that everybody knew, especially because we were only present for a part of the day, how that plan should be executed, ideally. And then we engaged in education. And again, we're going to hear from some of our resident participants, but we've also included a whole medical student rotation now on underserved medicine as a result of the global medicine pathway experience with the residents. So in the case of this patient, what we did was the following. We adjusted the ventilator settings. We did recruitability assessments bedside with the respiratory therapist. We titrated sedation infusions, gave them guidance on what to check, so triglyceride levels for propofol. We gave them recommendations for twitch monitoring, and we gave them things to look for. If the patient does X, Y, or Z for dysynchrony, you should think about doing this. We coached patients to prone patients. Sort of a surprise to us, but not a surprise to them. Not a single patient had been prone until the Tele-ICU was present. And that's not because they didn't know how to do it. They needed someone to say, yeah, you know what, go ahead and do it. And I think that's part of the reassurance and the trust that we were building with them. So I think that is one of the strongest successes of the program. We reassured them to use enteral nutrition. We talked to them about anti-thrombotic therapies. We talked to them about renal replacement therapies and involved the consultants as required. And we discussed the entire plan with the hospitalist every day in detail. And so that is kind of where we put our focus. And then when there are patients who really exceeded the capacities and really required that advanced therapy such as ECMO, we took that lead and talked to the transfer center. We talked to our colleagues at UC San Diego who we knew, and they trusted us in a similar way to know that the care was going to be continuous and the justification was solid. Okay, so I'm going to just give you three major areas of the highest yield for our ICU. One is that we created trust. Number one, this crossed the cultural context. This crossed geographic boundaries. This crossed technology issues. We're all on the same page. And as Dr. Mandel and Dr. Morris said, there are some high quality patient care. There was high quality patient care happening, and we built the team along with them. They were part of our team. So generating that trust was quintessential. We did that specifically in this case with creating clear and concrete and achievable goals. We weren't trying to, bring UC San Diego to El Centro. We were trying to find something that was a mutually acceptable approach. And this was clear, it had to be concrete, it had to be something that was realistic. We also wanted to create realism around where we were. When we started the program, I will say that some of our providers really felt that they weren't making a difference. They're saying, are we really helping them? It's not really sure, we're not really sure. But I think as the program developed, there was a sense of connectedness and a sense of common purpose that I think permeated that. And actually when at the end of the day, we felt like we were on the same team and that we were all achieving the same goals. The flip side was on the remote side. So at El Centro, for example, they had a feeling of inadequacy. Well, we're really not UC San Diego. We can't do that. Well, with prone positioning, with adjusting sedation, with all these other things, we provided the reassurance and we filled in some of their gaps so that they actually felt much more reassured by the care they were delivering. And this was actually reflected in some data that we collected. So before the Tele-ICU on the left figure, this is the perception of evidence-based care that was being delivered at El Centro prior and after the Tele-ICU. This is 2 months into the Tele-ICU service. You can see there's almost a 20% jump. And then the right side, you can see that in terms of staff confidence for taking care of patients, that for COVID-19 positive patients, about a quarter of the patients, a quarter of the staff felt that they were almost 100% confident, more confident than they were before the Tele-ICU. And what is interesting is that the Tele-ICU actually hardly ever saw a non-COVID patient. So you can see that the confidence levels actually increased even with non-COVID patients. So that means that there was a crossover effect in terms of the benefit. So could this be some sort of antidote against, the feelings of not having a rewarding care? Potentially, that still needs to be determined. So the last thing I'm going to say, and then I'm going to turn it over to the residents, we targeted specific educational opportunities. We wanted to create context-specific care goals. We did that by prioritizing. We couldn't cover everything necessarily, but we wanted to create a detailed priority. Then the second thing is we wanted to be efficient about it. We had to do care plans in seconds to minutes so that we weren't spending the whole day, and we couldn't cogitate for hours. And then we worked on communication, as I talked about, empathic, succinct, professional, collegial interactions, which sometimes we can't do as much in person. And then finally, we focused on certain things, and I'm going to show you some ventilator shots because what we could do here was focus on certain aspects. Let's just imagine you're in person. Sometimes you can't go in the room, or for staff exposure reasons, you want to minimize entry into the room. Well, we don't have that problem in Tele-ICU. We can zoom right in there, no pun intended. And you can see here a couple of different ventilator shots where we picked up on ventilator asynchronies that were quite illustrative, not only to our own physicians, but our trainees and the bedside staff. So here is an example of flow asynchrony. Here's an ineffective effort that we can see. The respiratory therapist is pointing out a question about the tidal volumes as they're dropping, another sort of flow asynchrony example, and then finally delayed cycling. So let me leave it there because I know we're running out of time, and I want to invite Doctors Crisp and Jones to kind of give their perspective.
And we usually run over by anywhere from 5 to 15 minutes because we do like to make sure we have time for Q&A. I don't see a whole lot of questions coming through the chat box, but anybody who wants to, please feel free. But yeah, let's have our internal medicine residents jump in and share some of their experiences.
Cool. Yeah, I think I'll go first, I guess, if that's cool with you, Alison. So I'm Neal. I'm one of the internal medicine residents. I'm an R3. I had the privilege of doing this early on into the year, and I had my doubts about it. I didn't know how this was going to actually be managed, how you're going to be able to do all of this care just kind of behind the screen. But it was absolutely excellent. I know that in COVID, we have problems, getting people in and out. And with this, a lot of places where they don't have access to a lot of these specialists, we were able to provide almost the same amount of care that we would kind of in inpatient rounds because we could even get them to do all of the physical exams that we needed to, and we could be right there with them and walk them through it if we needed to. And then even looking at the vent settings, and as a resident, we're trying to figure out how the whole mechanism works and how the flow of things. And it seemed like at first it was a little bit scary, but it definitely, within the second time we did it, it was a lot more at ease, and we're able to figure out things. And you could actually focus more on teaching as a resident because you could look at all of the labs and all of the blood gas and try to figure out what you should be changing in the vent. And you wouldn't get bogged down into too many of the little details. So honestly, I wish it was a 2-week rotation. We only actually spent 2 days doing it. So I'm actually privileged that I got to do it for 2 days. But if my one suggestion would be if we could do it even more than that. So I guess that's my 2 cents.
Yeah, I'm Allie. I'm one of the R2s at UCSD in internal medicine. And I echo a lot of what Neal was saying. It was an incredible educational experience for me as well. I really appreciate Dr. Ramnath for giving us the opportunity to be involved in the care that's being provided there. I think that just general learning about vent settings, about COVID management was very much there in the Tele-ICU as much as it would be in the in-person ICUs. Even more challenging sometimes because you didn't have time to be pre-rounding. You're sort of presented with an ABG and then making vent settings in the moment. Like Dr. Ramnath was talking about, sort of those quicker decision-making times. I think another thing that really stood out to me about it is how much the multidisciplinary team was so prominent in Tele-ICU. Really, the bedside nurses and the RTs, they're hugely influential in the ICUs here as well, but they're providing the exam. You know, when they were saying a patient was ready to extubate or needed to be intubated, they often were making those decisions and you were trusting them a lot, as well as the hospitalists who then, you know, you're there for rounds for a few hours, but then they're going to be caring for the patients for the rest of the night. So I definitely learned a lot. It opened my view of the possibilities for telemedicine as well. I honestly had no idea that Tele-ICU was a thing before this experience. So I really appreciated it. It was incredibly educational.
Thank you. Those are great perspectives. You know, I wish that I could have done a Tele-ICU rotation during training because, yeah, it just seems fascinating. Venktesh, I think, you know, some of the aspects that you touched on were like really cool. What did you find most challenging about trying to provide education? I know you put so much time and energy into, you know, doing this, but what did you find like you struggled with?
I don't know if creating anything from scratch. I mean, I think Dr. Mandel said that too, is you gotta jump in and start swimming. But I think just organizing things so that you have different systems that have different workflows, that can be sometimes challenging if you don't have a strong leadership structure. And I think Dr. Mandel said that we had backing from UC San Diego. From the top down. And I think that was crucial. And the detail, you need people who are sort of adept in operations. And so I know that with Drs. Crisp and Jones, one of the hiccups was getting them access to the electronic health record, just to get them to be able, and, you know, so we may think it's simple to have a credentialing office just sign the paper and, you know, but these are folks that are working really hard in smaller, again, resource limited settings. They don't have a battalion of folks to work out all the different, you know, credentialing needs of a large hospital. And so you have to build a relationship with them. In fact, I just did that 2 days ago. It actually ends up being fun in its own way. You know, you're building a family that is sort of remote, and COVID-19 has just made that more important than ever, and you can still make this a fulfilling experience. I will say one last thing is that, you know, we think that we are definitely strapped. Everybody's strapped. Everybody's working overtime and then some. But I have noticed, just sort of anecdotally, that our providers at UC San Diego who are involved in these kinds of efforts, cross-culturally in the border and everything, they feel better about doing the jobs at home, doing their regular responsibilities, because they have a better understanding of patients who are either being transferred from those places, but they also know that there are physicians and nurses and staff who are working equally as hard to try to get to the same goal. And that's what Dr. Morris was saying too, whether it's Tijuana, Mexicali, El Centro, you know, UAE, you know, India, whatever, we're all trying to get to the same goal. And knowing that and having that tangible is, I think, what makes us get up in the morning. So that's what I would say.
Awesome. Yeah, and I really feel like that came across, that this whole building of trust really has been, you know, paramount in both of the big situations that we've been talking about today. There was a question in the chat box about for Tele-ICU, at what point did you decide that this patient needs a higher level of care that Tele-ICU just couldn't provide? And then how did you proceed from there?
So that's a good question. I think that in general, the needs were the same in the sense of if you knew what the resource limitations are, like for example, El Centro, they do not have continuous renal replacement therapy. They do not have ECMO. They do have EEG, although it's limited. So if someone needed a continuous EEG. So I would say that most of the reasons for transfer were not unlike what any other, if you were in person trying to make that determination. And we do telemedicine in other parts of our network, but we also have in-person services. It's the same sort of conversation. So if you feel like a patient is better served in the sense of resources and expertise and maybe clinical experimental modalities or some of these super expensive therapies like ECMO, it's not going to really change a heck of a lot between Tele-ICU and in-person community ICU. And I've been doing this long enough for the last 15 years in both types of contexts that it's really the same. The technology is really not it's not the deal breaker. It's not the impediment. It's really about who's the operator. If you're feeling it, it's probably real, whether you're in person or not.
Awesome. Very clear response. There's another question in the chat box. Were your IT and informatics colleagues as enthusiastic and goal-driven as you clinicians?
I would say yes. I mean, I think that's part of the team you're building. It's not just a clinician team. It's a multifactorial, multidisciplinary team that includes everyone from transfer center coordinators to IT technicians. And we had the luxury of a precedent in telemedicine at El Centro, but in Tijuana and Mexicali, we didn't. We had to build that up from the ground. And that's where the work of Drs. Mandel and Morris were critical in establishing that trust early on and finding who the key decision makers were to be able to execute anything on a remote level. And so with El Centro, we had the luxury of some telemedicine services already. We had a telestroke service, so we actually kind of borrowed one of their units, even though it was kind of outdated. But all the other infrastructure we had to build from scratch. I had to build relationships with the new CIO, the Chief Information Officer. I had to work very closely with the Chief Medical Officer, the Chief Nursing Officer, with the Credentialing Office. I mean, there are all these different aspects to pulling off a program. And again, the telemedicine was the technology was not the crucial factor.
I would just say it's hard, I think, for people who aren't in the region to have a sense of the urgency of this. This was not some elective, hey, wouldn't it be great to build this with this hospital? Imperial County has by far the highest COVID rate per capita of any county in California, almost twice as much as the #2 county. I mean, and you have El Centro is a city of 42,000 people. So you can imagine the medical infrastructure is not great. Down the road is Mexicali that has 1 million people. And so, many of whom are US citizens, travel back and forth freely. So, I mean, this was a problem, a challenge for the whole state. As Venktesh said, we were evacuating patients regularly to Sacramento, to, all over the state of California. So there was a high degree of motivation from all the institutions involved, from the IT people. Everyone really recognized how critical it was to get this working well, and it was very, very helpful in overcoming roadblocks.
Yeah, it really sounds inspirational, just all this that went down, and just inspiring across, multiple levels of both, the clinicians, like the staff that's helping, and then, the people that you're working with. So yeah, sounds really fantastic. It is 9:04 Eastern Standard Time, so we're going to start wrapping up. Thanks for all the great comments in the chat box, and thank you to our fantastic experts. I didn't want to cut anybody off. If anybody has any final thoughts that they wanted to share before we sign off. Nope. Everybody happy? Great. Awesome. Well, again, thank you everybody for joining us tonight. We'll be back next week, 5 o'clock Eastern Standard Time, where Dr. Nirav Shah is going to be talking about some of the cardiac complications of COVID. And you can find all of our sessions recorded on the ATS website at all. And before you sign off, please do give us feedback. Tell us what you want to hear about next. Thank you and good night. Take care.
Thank you all. That was fantastic.